Good evening, and thank you for joining our virtual community lecture brought to you by Providence Little Company of Mary Medical Centers, San Pedro and Torrance. Our focus tonight is on weight management. I'm Karen Allen, the bariatric coordinator at Providence Little Company of Mary. Our guest speakers include bariatric experts, Dr. Solomon and Dr. Stanchek. Thank you both for being here to educate us on the latest in weight management. Before we get started, I want to tell everyone that this is an hour-long presentation and we will have plenty of time for questions at the end. Please use the Q&A box to type your questions and we will do our best to answer at the end of the presentation. Please note we are not able to answer personal medical questions, but will certainly answer general bariatric health questions. If we are unable to answer your questions, please feel free to email lalectures@providence.org and we will get back to you at our earliest opportunity. I would also like to share some information regarding our bariatric wellness centers. The Bariatric Wellness Center at both San Pedro and Torrance provide top-tier advanced treatment for weight loss management, as well as comprehensive surgical and non-surgical weight loss programs tailored to your personal health goals and preferences. Our positive approach to weight loss is holistic, which means we provide ongoing physical, nutritional, emotional, and spiritual support to help you realize your weight loss goals. I want to also mention that both of our centers are accredited by the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program, which is important because the organization ensures that our centers provide safe, high-quality care. Lastly, the information provided during this program is for educational purposes only. You should always consult your healthcare provider if you have any questions regarding a medical condition or treatment. It is now my pleasure to introduce Dr. Solomon, who will provide insights into weight gain prevention and weight loss medications. Dr. Solomon is the medical director of the Bariatric Wellness Program at Providence Little Company of Mary Medical Center in Torrance. He is double board certified in general surgery and obesity medicine. He completed a fellowship in advanced laparoscopic, bariatric, and robotic surgery at Stanford University Medical Center. Without further ado, please give a warm virtual welcome to Dr. Solomon.
Good evening. Thank you, Karen. And thank you, the entire Providence team, for putting together this wonderful meeting together. Let me get to my screen here. So, and of course, thanks everyone who joined us on your busy Thursday evening. Tonight we're going to talk about weight loss with medication, help with medication, and of course with surgery, as Dr. Stanchik will talk about. This is a subject near and dear to my heart. I've been doing work in weight loss for close to 2 decades, and I really enjoy it. It's very rewarding for me. And I think that it's always a real privilege to help people do things that they always had a hard time doing on their own. So, like Karen mentioned, this has become an actual specialty, not just the surgical aspect of it, which I do, and that's my formal training, but also the weight loss without surgery aspect, which now is a board certification, which I also have. So, a little statistics about obesity. As many of you know, obesity is rampant in the US. Majority of US population is actually in the obese category, and also a good percentage of children now are in the obese category. The cost of it is approximately 200 billion a year. Okay, say hi to my daughter. Can you go upstairs, Papa? No. Oh, thank you. Go upstairs. Go upstairs. Okay, go. Sorry about life of a father. Anyways, Obesity also has a mortality associated with it. And as time goes on, the number of deaths per year from obesity going up, and comparatively, um, the numbers of death from cigarette smoking is coming down since World War II. This is not the results of the last election, but it is actually uh, the CDC's data on how obesity is progressing. And the more red the states get, the more percentage of obesity is happening. So they started keeping track since the 1990s, and this is the last 4 decades. This slide plus this one, the 2020, and you see how rapidly growing this problem is. Last year, a good percentage of the states actually had 45 to 50% of their population, meaning 1 in 2 people in the states were obese. So it's definitely a public health issue. It is also very definitively linked to other issues, medical issues, as many of you know, diabetes, hypertension, cholesterol, sleep apnea, joint pain, back pain, everything, including infertility. Some people were not aware. There was a very new study done to measure how likely it is that if they're only heavy, if they only carry extra weight and they have no other issues, have a risk of having a cardiac event, meaning heart attack or stroke. And there was a direct link only from being heavy um, to cardiac events. It's also known that obesity is linked with some hormonal changes and also a constant increase in inflammatory markers in the body. And those two, namely hormonal changes and uh, rise in the inflammatory milieu of the body, give uh, direct links to 13 different cancers, at least that we're aware of. So what happens basically is that when someone has extra fatty tissue, the fat in the body changes the balance between estrogen, testosterone, and that causes some of these cancers. Um, Additionally, what it does is that adipose tissue or fat has a constant inflammatory effect on the body. So that's how it can affect some organs and cause cancer, and also that is how it's theorized that cardiac disease is caused by damaging blood vessels when there's no um, high blood pressure or cholesterol in some, like the slide I showed previously. So without question, obesity is a big target for all of us who are concerned about it. It's a big public health issue. So, like many other major medical centers in 2017, we started working on a weight loss center. We called it Bariatric Wellness Program because it encompasses surgical and non-surgical treatment of obesity. And our goal was exactly that, to treat the entire spectrum of obesity with the best tools there is, be it medication, be it education, be it surgeries. So we have an army of well-trained practitioners, everyone from surgeons and bariatricians to subspecialists or nurses, dietitians, etc., to help with this big project. And 2 years later, we were nationally recognized um, by MBSQIP, and we have been recertified 3 times since then. So, as you may have gathered, there's 2 pathways for weight loss. One is with surgery, which we do, and one is without, which we also offer. We have been for a long time. So I'm going to talk about the non-surgical pathway for weight loss. This has gained a lot of attraction with the recent introduction of a lot of the obesity medications, quote unquote, the Ozempic class of drug, Mounjaro, Wegovy, those things. But it's been around for a very long time. We'll go into medications and how effective and necessary they are in a second. But our program begins this pathway with an initial visit with myself or my partners. We basically want to gauge your challenges with weight loss in the past, how successful or unsuccessful you've been, and what are your exact needs when it comes to um, weight loss. We try our best to custom make a diet and exercise program for everyone. This always includes multiple visits to our weight loss specialists, dietitians, and of course we can guide you regarding local gyms, exercise habits, etc. We have built a relationship with several of the gyms in the South Bay. We do our best to make best use of weight loss medications, which have become more recently a game changer in our practice. We also have access to psychologists, therapists, if somebody needs it. Everybody, I'm sure, is aware that obesity is very much a multifactorial um, pathology disease. And very often we need to address all aspects that have contributed to it. And we also have a very close follow-up that occurs between every 4 to 6 weeks as we try to modify and refine the diet and exercise regimen and also the medications that we have uh, prescribed. So there's some very important fundamentals that need to be appreciated. There is, I'm sure everyone on this call has tried different diets. Um, there's probably over 200 different diets out there, quote unquote. They all work as long as you're able to keep up with it. But once you stop or you fall off the wagon, so to say, the weight comes back with a fury very often. So, what does work is a lifestyle. So, we try to present to you a lifestyle that is, of course, feasible physically, socially, financially, and physiologically. That last aspect, the physiologic challenges of weight loss, is super important and underappreciated, and that's where medications come. Fundamental number two is calories in versus calories out. This is the law of the universe. We want you, no matter what you do, to be in calorie deficit. If someone takes in less calories than they burn, there will be weight loss. There is very often a lag, especially for women, between the time you start calorie deficit and the time that the body finally lets go and the weight loss comes. But that is definitely needed. As a rule of thumb, anytime anyone, any one of our audience is doing some kind of a lifestyle modification, diet, call it anything you want, call it anything you want, and there is no weight loss, that means that this formula is not in place and needs to be refined, needs to be adjusted. Goals are again to decrease total calorie intake, to create portion control, and decrease intake of calorie dense foods. Calorie dense foods are things and foods that they pack a pretty big punch in a small package. So, perfect example is like sweets. A small muffin, it's about 200 calories, maybe more. And it takes 5 minutes to eat. So we try to avoid those and increase the intake of not calorie dense foods like vegetables, and that's the perfect example. And uh, loosely speaking, for anyone who wants to have some guidance based on this lecture and get started, we recommend to minimize carbs and fats and increase vegetables and lean protein. Lean protein means low fat protein. So carbs and the fats are the types of foods that we do need, but we need in the least amounts. And there'll be a slide that I'll share with you and you'll see why. Protein, especially lean protein, is the food that is perfect for purposes of weight loss because it curbs hunger most gentle way and the best and long lasting. And the slide that I'm going to show in a minute will explain. Veggies is the other important part of losing weight or the proper diet for weight loss. And it's because veggies are not calorie dense. And this is the kind of food that you could eat it pretty much all day and it would not amount to a lot of calories. So we use veggies, especially leafy vegetables, to be a filler so that your stomach feels full and you're not feeling empty. Now, a word about carbohydrates. Why are carbohydrates such a big enemy to weight loss? So, we need carbs. As human beings, we need carbs, fats, and protein. The problem with carbs and most of the carb that is available to most of us is that it's refined carbs. It's not complex carbohydrates. So when, let's say, someone eats a cookie, it tastes good. I love cookies. And the blood sugar goes up dramatically and very quickly. So if you see in this graph, the blood sugar rise is quick. It's called a spike. And while the spike is happening, we feel good, our mood is right, everything is great. Except that blood sugar drops down dramatically with simple carbohydrates. And once that spike starts heading downwards, then it's called a crash. It's no longer a spike, it's a crash. We don't feel good, and that will make us want that sensation initially again, and then we go eat something. So some of you may have heard the expression, carbs will make you want carbs. And that is absolutely true. One quick trick that anyone who's interested in weight loss can do is that you should not have any simple carbohydrates until early afternoon and see how your hunger behaves. Once you start the day with simple carbs, this up and down spike will continue. So this is why minimizing carbs is so important for weight loss. So this graph or picture is supposed to demonstrate why we like protein as the food that curbs the hunger the best. So if you recall, I said, loosely speaking, if you want to start dieting, quote unquote dieting, you want to have a diet that's minimal in carbs and fats and higher in lean protein and leafy vegetables. So if you see carbs at the very left, that's how blood sugar behaves. Really fast rise and a really fast drop. We don't want that because of what I just described. We will feel. Second to that, or at the very, I should say, at the bottom, fat, it's a very, very slow rise as the body takes a while to digest it and make the fat into blood sugar, and a very, very slow drop. Except that the peak for the fat is not enough to really satisfy people. We will still be hungry. Protein is the perfect middle. So very gentle rise and high enough response in blood sugar that we will be satisfied and a very gentle drop. And that's the best way to curb hunger. So again, the diet we recommend is low carb, low fat, high protein, lean protein, and vegetables. So continuing with the fundamentals, not every person will respond to the same diet. And when I say diet, I'm using quote unquote. We're talking about lifestyle, not diet, but the way that we eat diet. So everyone should be ready to modify the plan. That's something that you can't necessarily guess on your own. It's best done by physician supervision or a dietitian supervision. And women, unfortunately, you have to work harder than men to achieve the same amount of weight loss. This has very often has to do with muscle mass. Men, by nature, because of their testosterone levels, it's a lot easier to have more muscle mass and make more muscle mass with exercise. And muscle is the thing that has a higher metabolic rate. So a male that weighs, let's say, 200 pounds compared to a female that weighs 200 pounds, same age, same height, same weight, same everything, the man doing the same diet will respond a lot faster than the woman because their caloric consumption is higher since they have more muscle mass. May seem really unfair, but actually there's a way around it. Um, same, same sort of injustice, if you want to call it, with age. As we all get older, our consumption of calories drop. We just don't need as many calories. So if you're trying to lose weight, again, we have to work harder to achieve the same amount of weight loss. Now, when a lot of these diets that are out there, they have a extreme component to them. Zero carbs, zero fat, high fat, etc. So those don't work because they're extremes. It's hard to really keep those up. And so whenever we make a plan, we do our best to do something that's sustainable. That's why I didn't say zero carb or zero fat. I said low carb, low fat. Zero anything is not going to be very sustainable. The only exception I would say is zero soda. Soda should be banned, if you ask me. And that's that. And of course, you will do far better if you have someone looking over your shoulder. Losing weight, especially without surgery, believe it or not, is a lot more complicated. And I'll give you a piece of data. Of all people who engage in weight loss and are able to lose weight to their target and keep it at that level for a long period of time, only 5% in general succeed. So 95% of everyone who attempts some kind of weight loss, they don't get too far. Now, again, fundamentals, our goals, the flip side of the equation is to maximize caloric burn or calorie output, and that comes exercise. We, all of us, sitting, breathing, talking, walking, working, driving, um, digesting food, anything that our body does burns a certain level of calories, except for people who are trying to lose weight, it is not enough to put you in calorie deficit. So the only way to up the calorie burn is exercise. It's good for weight loss, it's good for our minds, our tranquility, it's good all around. So to make a dent in and have a meaningful amount of weight, we're not talking about what American Heart Association recommends for minimum activity level. That's a different thing. We're talking about weight loss, which is substantially more exercise uh, in terms of hours and in terms of intensity than activity level. So in general, any of you who are interested in having weight loss, You have to have exercise. A lot of people start with walking, and that's okay. But walking in general is a very, very low impact, low calorie burn type of activity. It's not, for most people, not going to be enough of a calorie expenditure to make a difference. So, exercise, in my mind, in my world, by definition, has to have some degree of intensity. It has to raise your heart rate and respiratory rate above normal and as high above normal as possible. In addition to exercise, you want to make it so that you, on day-to-day activities, you have an active lifestyle. You want to take the stairs at work. You want to park your car far from where you're going. Socialize over walks, hikes, etc. The newest thing is stand-up tables. Stand up at work or take uh, breaks during work and do some air squats, etc. Anything you can do to burn more calories. And I always give an example to sort of uh, make my point. Losing weight without exercise is like driving a car with three wheels. You, with some scratching and screeching on the road, you will get to where you need to go, but it is way, way harder. So now on to medications. On the left are the so-called older generation of medications that have been around for a very long time. On the right is the newer generation of medications that are not as new as you may think, but the quote unquote newer generation, the Ozempics, Wegovy's, Mounjaro, etc. So we have used medication for weight loss for literally for decades, several decades. And the ones that we use all are safe. The safety profile are absolutely acceptable. Each medication has a side effect, and we'll talk all about that. But they're absolutely necessary. They're a tool, and without it, again, it's going to be difficult. So let's talk about how effective the medications are. First of all, they are an important adjunct to modern way of uh, bringing about weight loss for people. The role of the medication, for most part, is to help the individual stay on track and reduce food noise. Food noise is this terminology that we use for people's preoccupation and sort of obsession with food. There's a lot of people that complain that from the moment I wake up to the time I go to bed, I have this buzzing noise in my head that what am I going to eat? What are we going to eat? When are we going to eat? When to take the break, etc., etc. It's just a big preoccupation with food. So these medications are designed to quiet that so that the individual can focus on what they're supposed to do. Now, not all medications work the same for everyone. They have variable effects on people. Most successful medications, to our data, and again, this is average, they result in about 20 to 25% body weight loss. Some people do a lot more, some people do a lot less. It's variable, but on average, that's the range. Now, another very, very important thing is that if you stop the medication, for majority of people, the weight comes back. And now that's again not everyone, but for a lot of people, the weight the medication stops, the this big help that it brings about also stops, and the individuals they regain the weight. Now, there are some exceptions. There are some people who just need a little bit of help getting started, and once they get on track, they get super motivated, they can focus and they go. That is definitely we see, but this is an important thing that if Some people think that I'm just going to go on medication for 6 months, lose the weight, and be done with it. That is not how it works for most people. Now, is that okay? And the answer is yes. So, any of you, if you came to the office and I said, your cholesterol is high, we need you to put you on cholesterol medication, you would not have a problem, even if it was for the rest of your life. Same thing for diabetes, same thing for high blood pressure. So our view of obesity is that it's a chronic condition. It's something that affects your entire body and it's out of your control. When we say chronic, meaning it means that it's that it's there, you cannot control it, it's essentially out of your control and you need help. So it's treating obesity is just like treating blood pressure, cholesterol, and being on medication for it for life is absolutely 100% okay. Now, safety of medication. One very, very important thing that I want to recommend to everyone that's listening, please do not get your information on health and health issues and medication from the internet. Internet is good for many, many things. It's definitely good for what you want to buy, Amazon, shopping, get good deal on A, B, and C, but it is absolutely terrible place to get advice on health and health issues. So there's a lot of um, misinformation on the internet about Ozempic. It causes this, it causes that. Same thing that it was with COVID vaccine previously. The truth of it is that the Ozempic class of drugs, as I refer to them, a lot of people refer to it, or what we call GLP-1 receptor agonists, they have been on the market without significant issues for close to 20 years. The first medication, I think, came out 18 or 19 years ago, and that has been used for diabetes for that long. And it works fine and is absolutely safe. Now, just like all other medications. You're not going to go just get it on your own and go at it. These need to be prescribed by a healthcare practitioner, physician, PA, nurse practitioner, and you need to be monitored until you reach a stable level. And then you will not need as much monitoring, but still you will need some monitoring. So that's the truth about medication. All the medications that we prescribe, they're all safe. They're all FDA approved. Um, the Ozempic class of drugs, one or two of them are approved for weight loss by the FDA specifically, but it is absolutely okay to use all those medications for weight loss because they do the same thing. The manufacturers have not applied for weight loss. In the future, most likely all of them will have the label for weight loss as well. Now, any medication can have a side effect. The most benign medication, Tylenol, can cause a rash that some of you may have experienced. That does not mean that they're bad medications. Side effects are possible. Again, if the medication that we prescribe you causes you a problem, we just stop it and that goes away. And that's the end of that. Then we move on to the next one. We have had some fantastic results with the GLP-1 receptor agonists. We have people who've lost over 100 pounds and they feel amazing and they never blinked, what's the expression? So they never had any issues at all. But the most common side effect for this class of medication is nausea and constipation. Normally, when somebody starts these medications, nausea is common. Usually it's short uh, and we will go away. Sometimes when you go up on the dose, then nausea begins and again with time goes away. Majority of people do just fine on these class of medications. Some people don't, and that's the end of it. We move on to the next one. But safety is not a concern as long as it's done in a reputable program. So how do I do it? Once we see you, in short, we send you to a dietitian. We see what your needs are. Again, we recommend minimum of 4 hours of exercise per week. Some people need more. Some people could get away with less. We discuss what's called My Plate with you, which is basically our short and sweet recommendation how to eat. Basically, you're going to start eating from a smaller plate. Half or more of it should be uh, vegetables, leafy vegetables, and the rest should be lean protein and a small amount of carbohydrates. Two of the meals should be in that structure, lunch and dinner. My personal favorite is to have as big a lunch as you can inside that structure and make your dinner the smallest and your breakfast somewhere in between. That is a formula that works for me personally. It works for a lot of people. Dinner, no matter what, should be your smallest meal. And of course, we start you on uh, medication as well, if you agree to it. If not, then we do it without. So this is a picture of my plate. Um, you see half of the plate is vegetables. I would prefer if there was more of the veggies and less of the carbohydrates in the top corner. And usually the carbohydrates, if we can make it complex, so for example, brown rice or whole wheat bread, that sort of thing, it's even better. Okay, a little humor to end the talk with. So this was my little spiel on how we do um, weight loss without surgery. Of course, surgery we also do, and that's something somebody desires, then we're happy to offer. Okay, thank you. We'll wait for the questions at the end.
Thank you, Dr. Solomon, for your wonderful presentation. Now it's my pleasure to introduce Dr. Stanchak, who will share the latest advancements in bariatric surgery, including robotic-assisted surgical options. Dr. Stanchak is the medical director of the Bariatric Wellness Center at Providence Little Company of Mary Medical Center, San Pedro. She is a board-certified bariatric and general surgeon who specializes in weight loss surgery. Dr. Stanchak has performed more than 3,000 successful weight loss surgeries, helping patients to improve their health and quality of life. Dr. Stanchak, you have our attention. Dr. Stanchak, you're muted.
Oh, I'm sorry.
There we go.
Thank you so much, Karen. Thank you so much, Andrew. And I want to thank you entire Providence team for allowing us to speak to you about very important subject, which is a weight loss and what we can offer to help you become healthier. My name is Dr. Stanchik. I'm medical director at San Pedro Medical Center, Bariatric Wellness Center. I want to talk today about the weight management and surgical option. I want to thank you and congratulate Dr. Salomon for his fantastic presentation. Lots of very important information, not just for medical, but also surgical weight loss. I'm going to talk about obesity just very shortly because I think this is something which we have to understand, that obesity is an epidemic, not just in the United States, but also all over the world. Obesity was named by World Health Organization a chronic progressive disease resulting from interaction of multiple environmental and genetic factors resulting in the disorder of the energy balance. It's very important to understand that obesity is not just a simple disease. It's chronic, complex, and if we don't do anything, it's going to progress and get worse. Obesity takes a toll on our entire body and on every system of our body. Multiple studies were done which showed that obesity will weaken and impair our body immune system and cause chronic inflammation. It will increase the risk for many diseases and disorders, including cardiovascular disease, hypertension, strokes, diabetes. Metabolic disorders, including polycystic ovary syndrome, as well as in infertility, and also is implicated in multiple cancers, as we can see. But not everybody recognizes that obesity also can shorten your lifespan. And if you are a 20-year-old man with BMI of 45, which is roughly about 100 pounds over your ideal weight, your life can be shortened by 13 years. There are different treatments of obesity, as Dr. Salomon was saying, lifestyle modification, medication. They are very good for lower body mass index and patients who don't have multiple comorbidities. However, when we're dealing with patients whose BMI body mass index is high, or we have multiple comorbidities, we also can offer something else. And this is bariatric obesity surgery. There is no one surgery which fits all. We have different types of bariatric surgery. We have bariatric surgery, which is restrictive when we do not cut or changing the gastrointestinal tract or stomach. They are metabolic and restrictive surgery like sleeve gastrectomy, when we do change the gastrointestinal tract and we're taking away a portion of the stomach, and also metabolic and restrictive, as well as malabsorptive surgeries like gastric bypass, duodenal switch, biliopancreatic diversion, and many more. So when we have so many choices, why do we actually consider bariatric surgery? Since beginning of 90s, we knew that this bariatric surgery, that the surgery is one of only effective long-term treatment for people with severe obesity. We have multiple institutes and clinical associations which are endorsing bariatric surgery as a preferred treatment, especially for severe morbid obesity. Despite all this endorsement and long track of good results with bariatric surgery, we're still operating only on less than 1% of people who are good candidates for bariatric surgery. So who is a candidate for bariatric surgery? We're looking at our patients before we look and propose different treatments, not just from the degree of obesity, which is one of the most often used, but also from the overall health. The patients whose body mass index is more than 40, which is roughly about 100 pounds over ideal weight, despite lack of any coexisting comorbidities, they are a good candidate for bariatric surgery. If a body mass index is 35 or above, and the patients do have comorbidities, at least one of them, including diabetes, cholesterol, hypertension, fatty liver, and many, many others, they are a good candidate for bariatric surgery. In 2012, National Institute of Health revised the guidance for bariatric surgery and added another group, which is a group of patients whose BMI is between 30 and 35. However, if they do have diabetes or metabolic syndrome, hypertension, hypercholesterolemia, we noted on multiple studies that they will benefit from bariatric surgery, especially these days when there is a very low complications rate. So what kind of bariatric surgery we can choose and which one is best for you? That's a questions which we're always talking about the patients prior to surgery in our orientation. As I said before, we have multiple different bariatric surgeries. The adjustable gastric band, which is restrictive procedures, very popular about 15 years ago, required to put a specific device on the stomach, which is going to restrict amount of food we are able to eat. So, sort of like a double hourglass. We can propose gastric balloon, which is also restrictive procedure that may be done endoscopically. However, that type of surgery, it's a temporary. We keep the balloon for about 6 months and have to remove it. More permanent metabolic and restrictive procedure is a sleeve gastrectomy. In this procedure, we're taking away portion of the stomach, and that procedure requires us to cut on the stomach and change the anatomy of the GI tract. More complex procedure like gastric bypass and duodenal switch give us also advantage of malabsorption. It means that we're going to create a portion of the GI tract which is not going to absorb the food, and may increase the chances of different complications we're going to talk about. However, the most important part is to understand that the choice of a surgery, which surgery is the best for you, it depends on many factors. Patient's condition, comorbidities, surgeons and patient's preference, and of course, fulfillment of requirements. There was a very nice study which was published in Bariatric Surgery Journal in 2022, looking at number of surgeries we performed and type of surgeries we performed. As I told you, there's many different surgeries, and as you can see, some of them like lab band, decreasing in the number of surgeries, and some of them like sleeve gastrectomy or sleeve gastrectomy, they increasing. The gastric bypass have a tendency of decreasing and staying steady over the last few years. Looking at the number of surgery we performed in United States, for the last more than 10 years, we're performing more than 200,000 bariatric surgery a year. Since 2014, number one performed surgery is a sleeve vertical gastrectomy, which accounts for almost 60% of all the bariatric surgery. Gastric bypass is less popular, but it's about 20% of all bariatric surgeries. And altogether with gastric sleeve, they account for more than 80% of all bariatric surgery. So let me talk to you a little bit about sleeve gastrectomy and gastric bypass. Both of these procedures are bariatric and metabolic. It means that not just change the size of the stomach, but also cause metabolic change in our body. Dr. Salomon was talking about GLP-1s and injectable medication. They actually were found on studies on patients who underwent gastric bypass and sleeve gastrectomy, and that medication are pretty much based on the surgery. So after surgery, when we remove the portion of the stomach, we're also changing the neurohormonal response to the food and metabolism. Majority of patients who undergo bariatric surgery, they see immediate change in appetite. They are not hungry. They can control how much they eat. That is mostly due to decrease in the level of ghrelin, which is otherwise known as a hunger hormone, which helps us control how much we eat, how often we eat, and also helps us say no to the food much easier than before surgery. Both of the surgeries are done laparoscopically, which means they are done minimally invasive through the very tiny holes, size of a pen. Both of the surgery also are done robotically. robotic and laparoscopic approach is a minimally invasive approach, leaving you with tiny scars, the same like with cholecystectomy. Both of these surgeries required, however, to be done under general anesthesia. It means we're going to put you to sleep, and required to be done in a hospital setting. Sleeve gastrectomy is a surgery when we making your stomach much smaller. The stomach size is the size of your open hand. In order to create a sleeve gastrectomy, we will resect about 75 to 80% of your stomach. In order to make all the stomachs the same size, we're placing in the stomach the tube, we call it orogastric tube, and we transecting your stomach along the tube, making sure that stomach which is left with you is the same for everybody. The doctors use different size of a tube. The average tube is about the size of your finger. The time necessary to create the sleeve gastrectomy is about 1 hour, anything from half an hour to hour and a half. Post-surgery, the patients are recovering in hospital overnight and usually are sent home next day. In sleeve gastrectomy, except creating a small baby stomach, there is no change in GI continuity. It means that we're not changing the way how the body absorbs, and we're not changing we're not creating the new anatomy. The possible protein, caloric, or vitamin deficiency are very rare, however, can happen. That's why everybody who has any bariatric surgery should take vitamins, should take food which is healthy and follow healthy food choices. The anemia is seen rare, but it also can be seen. However, we do not change the absorption of the iron, so that's why the patients can take regular medication the same way like they're taking prior to surgery. The complications after bariatric sleeve gastrectomy, they are similar to any other bariatric surgery. What we're worrying the most is a leak, gastric leak, which happen in about 1 to 3% of the patients. It's much less this day, thanks to advancements in technology. Bleeding can happen as well. Bariatric surgery, sleeve gastrectomy, and gastric bypass is a bloodless surgery. We're losing about 10-15 cc's of blood. However, there is a potential of bleeding. That's why we always look for that, and it can happen. What we as surgeons worrying a lot is a blood clot formation in your legs. Deep venous thrombosis and pulmonary embolism can happen, rarely, but can happen. That's why there is special preparation prior to surgery and after surgery when we're giving you a medication to minimize that development. Other complications like gastroesophageal reflux, esophageal dysmotility, gastric outlet obstruction, stricture, kink can happen. We're seeing them very rarely. Retractable nausea and vomiting, it's also seen very rarely and usually improve or resolve as we go further down from surgery. The splenic injury can happen because the spleen is attached to the stomach. We have to detach the spleen from the stomach, and that sometimes can cause something called splenic infarct, usually which has no major consequences. Mortality and morbidity from that surgery is very, very small. The average weight loss is about 70% with a success rate of 5 years of about 64%. The gastric bypass is another metabolic and bariatric surgery. It's more complex than a gastric sleeve. In this surgery, we changing the anatomy and gastrointestinal continuity. We're creating a small pouch, which we're cutting off from the stomach. The pouch, the size of the thumb, about 15-20 milliliters in the size. We have to transect the small bowel because we're creating connection between the pouch and the small bowel, creating a ruling. And we're also creating a specific road for all the stomach acids and biliary juices to go completely separate way. With a gastric bypass, we changing the anatomy and creating separation between alimentary route when the food is going to go from your mouth to the esophagus, small pouch, and straight to the small bowel, and traveling that small bowel for about 3 feet on its own without any other juices except your saliva. All the juices from the stomach and liver and pancreas, they're going to go separate road for about 2 to 3 feet before joining the food and digesting, absorbing the way how it's happening right now. That change allowed us to separate the alimentary tract from the biliopancreatic tract, and that allowed us to separate the acids. So if you suffering from gastroesophageal reflux, if you're suffering from acid burning your esophagus, and you have to sleep sitting up and take proton pump inhibitors, that surgery is definitively a surgery which is going to help you a lot because of the separation of the alimentary route and biliopancreatic route. We're going to improve the gastroesophageal reflux problems. The OR time with that surgery is about 2 hours because it required us to perform 2 anastomoses between the stomach, small bowel, and the small bowel itself. As I said, we're creating complete change in GI anatomy, bypassing a portion of the stomach and the duodenum. That portion which is bypassed, it's not accessible for us to be visualized through the endoscopy or any means of direct evaluation. So we're creating portion of the GI tract which is going to be staying with you. However, we can't see that portion directly. Because we're bypassing part of your duodenum where the most of the absorption of iron happened, but possibility of anemia is unfortunately increased, and you will have to take some iron and vitamins in order to prevent the anemia development. That is also true to some vitamins and minerals. After gastric bypass surgery, we will recommend that you will go on a bariatric multivitamins and minerals, which is going to give the highest degree of absorption. The complications related to the gastric bypass are very similar to other bariatric surgeries. The same anastomotic staple line leak is something what we're worrying the most and happen very rarely, between 1 to 3%. Marginal ulcer may happen more often with gastroesophageal reflux. It's an ulceration between the stomach, gastric tissue, and small limb, small bowel tissue. The GI bleeding happened very rarely, as well as gastrogastric fistula, which is a connection between the pouch and the old stomach, or candy cane abnormalities. So the complications are very rare, however, can happen, but it's very important to take good care of them. So complications after bariatric surgery, as I said, they are very rare. In hospital, it's less than 10%. And we had studies of 106 different centers, which are part of excellence programs, which showed us that incidence of readmissions about less than 5%, and incidence of reoperation is less than 3%. In both of our centers, that incidence is much lower. So we're doing great from that standpoint. The 30-day mortality from bariatric surgery, it is very low. It's about 0.1 to 0.3%. When you compare with different upper surgeries like laparoscopic cholecystectomy or hip replacement, something which is much, much lower. And when you compare to really surgery who has a high risk like CABG, which is a cardiac bypass, that that mortality is 30 times lower. Of course, we're always worrying about the complications. And in 2007, it was a very nice publications, which specifically pointed the risk factors which can increase obesity surgery mortality risk. And that 5 factors is a body mass index, is how big the patient is. Male gender, which means that the distribution of obesity is mostly abdominal. Presence of hypertension, congestive heart failure, presence of history of DVT or PE, as well as age over 45. All these risk factors, when then combined together, they can increase the risk of mortality and morbidity. We can't actually change many of them because the age is something which you won't be able to change. Distribution of obesity as well. However, we can change body mass index. We can change the weight. So many times we like our patients to lose weight prior to surgery, and we like also operate on patients who are not a high risk for bariatric, for any surgery, especially bariatric and metabolic surgeries. So before, if you're thinking about bariatric surgery, think about doing that maybe sooner or getting information sooner than later, before you develop any serious comorbidities, before body mass index increase and you get older, because that all of that is going to put significant change in a risk of that surgery. Outcome after bariatric surgery, especially resolution of comorbidities, is amazing. We know from multiple studies that bariatric surgery improves or resolve the various disease like diabetes, decreases significantly cardiovascular risk, and helps resolve polycystic ovary syndrome and infertility, hyperlipidemia, and more. The bariatric surgery, it's not is able to give you not only a significant durable weight loss, but the most important part is going to make metabolic changes, which are independent of weight loss and are going to significantly improve your overall health. What it means when we're doing bariatric surgery, we changing the metabolic response, with changing insulin resistance. That's why bariatric surgery has excellent data on a resolution or improvement of diabetes, which we're seeing very quickly after bariatric surgery. When you have bariatric surgery and you're going home the next day, we have to adjust the medication for diabetes, for hypertension, because of metabolic effect on your body. We can't, many times we send you with no medication or with very minimal one, because if you will stay on the same medication from prior to surgery, that can increase the risk of hypoglycemia or hypotension, which is also very, very dangerous, the same like opposite. So obesity surgery treatment, there are different options. As I said, lifestyle modification and medication, they are good for some patients, and the surgery, it's good for others. However, which one is the best? That's the questions when we're always asking what to do. We had a little bit of help from the study done by Professor Jenkins from New York University, which was presented in San Diego on American Society of Metabolic and Bariatric Surgeons meeting from this year. The analysis of more than 40,000 of patients divided in the groups of bariatric surgeries, which we had total of 22,000 patients, 18,000 with gastric bypass and 6,000 with sleeve gastrectomy. We had a one systemic review of lifestyle modification and 6 different studies about medication, GLP-1s and injectables, semaglutide and tirzepatide, both of them very often used these days. So lifestyle modification interventions showed to be the least effective, as we suspected, and unfortunately, that modification allowed us to change weight loss of about 7.4%, and within the 4 years, majority, almost all the participants regained the weight back. The GLP medication, they gave us a little bit better effect. We didn't see statistically significant difference. However, the tirzepatide seems to give a little bit more of a excess weight loss for the patient. Both of this medication allowed the patient to lose about 15% of excess weight for semaglutide and 22% for tirzepatide. However, on both of this medication, when the patient stopped the medication within the 1 year, they regained the weight back. The surgery was the only measure which gives us good results with the weight loss. And after 5 years, both of the participants of both of the group, gastric bypass and gastric sleeve, they were able to keep more than 25% of the excess weight loss. Of course, we also noted that the length of the medication plays significant role in weight regain and the speed of weight regain, what we were seeing on this study. So in conclusion, the obesity as a chronic progressive disease should be treated with implementation of multimodal treatment with cooperation between surgery, medicine, dietary and lifestyle changes to achieve the long-lasting results. This bariatric surgery is a tool in our toolbox to help us lose weight and improve overall health. And many times we also have to use different modalities like medication and lifestyle changes in order to help the patient lose weight, sustain the weight loss, and continue to be healthy. Thank you very much.
Thank you, Dr. Stanchak, for that informative presentation. We have a few questions for our participants, so if you could please answer the poll that you see on your screen and share your honest feedback, we would greatly appreciate it. Our presentations were so informative tonight that we don't have any questions. So I feel that the audience definitely got a lot of education regarding medications and surgery options. So thank you for all attending this lecture and for your excellent participation. A big thanks to Dr. Solomon and Dr. Stanchak for taking the time to provide us with this valuable information. We will be sending a recording of the presentation to all attendees and we'll post it to our Facebook and YouTube page. As you can see from this map, Providence Little Company of Mary Medical Centers, San Pedro and Torrance have you covered. To find a physician or to schedule an appointment, please call our Patient Engagement Center at 1-855-415-8191 or visit us at providence.org and click on Find a Doctor in the navigation tab bar. We look forward to caring for you and your loved ones. Thank you again for attending and have a great evening.